Welcome, everybody, to Tuesday's episode. Today, I am speaking with my husband again. He's like a regular on the podcast. And actually, I was thinking about it today. Before I had Milo, I never really thought it would be so cool to be married to a urologist. But now that I've had a child and like I've experienced incontinence and like friends have come to me even with, asking questions about like circumcision and all this stuff. I'm like, oh my God, you're just so needed in the mom community. So
you didn't
welcome
think
back.
It was cool to be married to me when you married me?
Not really. I just didn't know how
Oh, okay. That's nice.
how important like all your wealth of knowledge would be. Let's say that. So
Thanks.
He is back. We're not recording in person. He's actually at work doing this on his lunch hour. So thank you for that. First, I'll just say that the Mom Room podcast is partnering with TENA. They are a leader in incontinence solutions products, and they want to help support new moms by creating a space for vulnerable conversations. And what better place to do that than the Mom Room podcast? So I am honored that they have chosen me to have this conversation. I've been wanting to do an episode about incontinence for so long because, again, it's one of these things that nobody talks about, like in public, but also within families and friends. It's just not like people just, and they make a joke about it. It's like, oh, like, I remember I posted a video not too long ago of my mom jumping on that rebounder thing. It's like a little mini trampoline. And so many people were like, oh my God, she's brave. I could never do that. And it's just kind of like this, I don't know. It's just people just kind of like brush it off like, oh, there's nothing we can do about it. But we are going to answer your questions that you submitted. And hopefully this is a super educational episode for everyone. I'm hoping that you will share it with your friends who have maybe had kids or are dealing with incontinence. And also, I just want to destigmatize incontinence and what happens to women's bodies in postpartum. So I'll give a little introduction to my husband, even though most of you already know who he is. He graduated from McMaster University in 2010, following a degree in kinesiology. Babe, you wrote this little introduction for yourself, and I was like, oh, I'm like learning about my husband. Like, I don't think I realized that you had a degree in kinesiology. Like, look at you.
Oh my God.
So yes, then he completed his residency in urology at the University of Ottawa in 2015. And while you were in your residency, that's when you met me, right?
I know, and it's gone downhill from there.
Yeah, right. Yeah. So since 2019, he has been a practicing urologist and runs his own...
2015.
Oh, since 2015?
Yeah.
Oh, yeah. Okay, yeah. Sorry. So he focuses on endourology, minimally invasive surgery, and urologic oncology. So yeah, thanks for coming on the podcast again and sharing your knowledge.
I was kind of forced to. I didn't really have a choice.
Oh, yeah, right. Okay. So the first thing we just wanted to go over was what the prevalence of incontinence is, because again, it's one of these things that people don't really talk about. And one of those things that if someone's experiencing it, they assume that nobody else is going through it. So what is the prevalence?
Yeah, so I mean, it's actually kind of a challenging thing to really determine because, as you said, some people deal with this, but they're not really bringing it up with their family doctors or physicians. So it's not always noted as to when people are having these issues. Some people, have a small leak every now and then. It's the end of the world. Some people are leaking every day and they don't bring it up because it's, they consider it to be normal. So it kind of varies with age, but upwards of 20 to 30% of women at some point in their lives will describe some degree of leakage. That can either be a couple of drops when you're coughing, laughing, sneezing, or it could be like full bladder emptying at times. So it's kind of variable, but that's sort of the numbers that when I speak to patients, I kind of quote them. 20 or 30% prevalence. There's different types of incontinence. So, the most common ones that we deal with are stress incontinence. So that's kind of when patients are laughing, coughing, sneezing, anything to do with exercise. So any activity where you're kind of increasing the pressure in your abdomen, that kind of puts pressure on your bladder. It adjusts the position of the bladder so it straightens out the urethra, and sometimes you can leak if you have weakness in your pelvic floor muscles. That's usually with patients who, of the 20 to 30% prevalence, it's about 50% of the patients who experience stress incontinence solely. Another type of incontinence called urgency incontinence. That's when patients have a strong urge to void and can't control it because that strength of contraction of the bladder kind of overwhelms your ability to contain it. That's about 15% of those patients, and about 35% have a mixed picture. So stress and urgency incontinence combined. Like I said, those are kind of the numbers that I quote patients when I speak to them.
So, with regard to postpartum, is it
Yeah.
mostly stress incontinence?
The majority of patients that I see who have had recent deliveries or in the last couple of years, majority would be stress incontinence. Yeah.
Okay. So now we'll talk a little bit about why incontinence happens in pregnancy and then also in postpartum, because I'm sure lots of
Yeah.
people don't even understand why it's happening.
So, I mean, during pregnancy itself, a lot of the issues can be related to the uterus, and as the fetus is growing and the uterus is getting bigger, it's putting more pressure in the bladder. So you have to look at, in terms of the pelvic organs, you've got the uterus, the bladder, and the rectum. Everything is in a relatively small confined space. So any increase in the size of any of those organs will put pressure on the others, right? So whether that's a uterus that has a fetus in it or a uterus that has large fibroids, that can put pressure on the bladder. That can also put pressure on the pelvic floor muscles and the nerves in the pelvis, specifically the pudendal nerve. So that can all have effects on your continence. With respect to the types of incontinence during pregnancy, certainly urgency incontinence can be one of them. The pressure that the uterus is placing on the bladder reduces the sort of capacity of the volume of the bladder, and it's also the pressure itself can induce these contractions of the bladder. So those two factors can kind of lead to urgency incontinence.
So I have a question. So in
Yeah.
pregnancy, because you can have let's say 10 pregnant women,
Yeah.
but some will have incontinence and some won't. So is
Yeah.
it because of maybe where things are located specifically in their body or where the pressure is being put? And
Yeah, exactly. I mean, and also the size of the pelvis, right? I mean, everyone's a little bit different in terms of their size, so it's gonna have varying impacts in terms of how extensive the issue is, right? Like how much you're affected by it is due to
so
your anatomy and the size of the fetus and that sort of thing.
so for me, because every time I saw a doctor when I was pregnant, they were like, "Oh, you're so lucky because you're so tall."
Yeah,
So there's more room for everything.
yeah, it's just sort of grow up instead of in and out, right?
Ah, okay, okay, okay,
Yeah.
okay. Okay, and so is there anything else for pregnancy or are we on to postpartum now?
No, so like I said, that was the urgency component of it. The other component is stress incontinence during pregnancy, and again, pressure on the pelvic floor muscles, pudendal nerve, all that can have impacts on sort of the strength of your sphincter contraction, which controls your urination, and also the position of the bladder. So it can create hypermobility in the bladder and the urethra, and that can lead to stress incontinence. You have to
Okay.
think of, your control mechanism, or your sphincter complex for urinary control for women is kind of like a hammock. So you got the urethra going right down the middle, and then your pelvic floor muscles going underneath the urethra. And that support of the pelvic floor muscles and the urethra allows for continence, right? So if you have any impairment to those pelvic floor muscles and their ability to contract or their strength, then you're going to have weakness, less of an ability to control that urination.
Okay.
Yeah.
Okay. And then in postpartum, so
There's
and there's
sorry,
there's
there's well,
always like sorry, okay, go ahead.
So there's other factors as well. I mean, there's hormone factors, so progesterone, another hormone called relaxin, which is at a higher release at a higher rate during pregnancy, can have an impact on smooth muscle contraction, and so that can also affect control of the sphincter and the muscles inside the bladder itself and the urethra, and that can also have an impact on cause or lead to uh, issues with incontinence.
Okay. And I feel like incontinence in postpartum is probably more common than in pregnancy. And why? Let's talk
Yeah,
vaginal birth
yeah.
first.
So, I mean, vaginal birth is a huge trauma to those pelvic floor muscles, right?
Mm-hmm.
So, it is certain, even if you have a C-section after you've been in labor for a while, or you deliver vaginally, that's going to put significant pressure on those pelvic floor muscles. It's going to have impacts on the pudendal nerve as well. Things like prolonged labor, a large baby, tears during delivery, all of those will have negative impacts on your pelvic floor muscles, and that can lead to stress incontinence, which is kind of the predominant type of incontinence after in the postpartum period.
Okay. And so, one question, why does it happen in some women and then not in others
Yeah.
after, like in postpartum?
So again, I mean, it's very patient specific. So in terms of the type of delivery, the number of deliveries you've had in the past, the duration of labor, tears, the size of the baby coming through, position of the baby coming through, whether it's breech or not. All those factors can lead to varying degrees of impact on your pelvic floor muscles. So it's very specific to this each patient.
Okay. Um, so now we're going to get into questions from listeners. So I put up a sticker on my Instagram stories a while back and we had a ton. Like when I tell you there was a ton, like there was a ton of questions. So what we
Not
did,
everything was related to this topic.
yeah, no, people like to throw things in there. But anyways, so we kind of put the most common questions together and made this little outline so that we could cover as much information as possible. And so the first thing that I wanted to point out and I thought we could talk about was the difference between something being normal and something being common. Because and the reason I wanted to talk about this is that I feel like people assume that it's normal and there's nothing that you can do. And by calling it normal, like it's not normal. It's something that's common. It happens in a lot of people, but it's not normal. So, can we talk a little bit about that? And then also what people can do, even like pre pregnancy or during pregnancy. Like, I remember when I was pregnant with Milo, the only reason I went and saw a pelvic floor physio, because I had never even really knew that that was a thing, but Lindsay, my friend in Sudbury, owns a physio and chiro clinic, and she was having this event one night, and I was like, oh, I'm going to go. And she had a pelvic floor physiotherapist give a presentation, and my mind was blown. And so I started seeing her in pregnancy, which I think like really was helpful. And then obviously I saw one in postpartum. So can we talk a little bit about how it's not normal, it is common, and maybe a little bit about pelvic floor physical therapy, like, and when should women be starting that?
Yeah. So I mean, as I said, I mean it's a relatively common thing to have some leakage during pregnancy and afterwards. This whole idea of normal versus abnormal is kind of, a very philosophical discussion here. But I mean, any degree of leakage, you know, relative to everyone else in the population is not normal.
Mm-hmm.
So I think it's, accepting that it's something that you can help, either proactively during your pregnancy or before, and sort of reactively afterwards. But as I said, it's a relatively common thing, but it's not something that you necessarily have to live with after you've given birth.
And also, I feel like it's something that limits people, embarrasses people, makes
Oh, for
people
sure.
feel
Yeah.
shame, which is why people don't necessarily talk about it. But if you are experiencing it, and let's say you're like listening to this podcast, and you're like, oh, I'm going to make an appointment with a pelvic floor physio, or I'm going to, ask my doctor to be referred to a urologist.
Yeah.
In the meantime, there are products that you can use so that you're not having to be uncomfortable during the day. You're not having to limit your what you're doing. Like you can jump on the rebounder like my mom did. And so I just want to mention that TENA does have incredible products. Some that you can wear during the day that literally look and feel just like underwear that will keep you dry.
Yeah, I
And
remember buying
also
those for you.
exactly, exactly. Like I wore those in postpartum for a long time. And yeah, super comfortable. They have nighttime options. And so it's just about like being confident during the day and not letting it completely like derail things that you want to do, whether it's like physical activity or, yeah. So were you gonna say anything else?
No, I think we're, in your outline, we are going to get to some of the other, like pelvic floor physio specifically and that
Oh,
sort of
okay.
thing. So,
Okay. So some people are, yeah, they were wondering if it will last forever. So I'm assuming these are women who are experiencing incontinence um, relatively shortly after giving birth. So is it going to last forever ever? And when do you seek help?
yeah. I mean, for a very small percentage of patients, who are experiencing incontinence immediately after pregnancy, they may have long lasting incontinence following that. And really, just like any other medical issue, the sort of the need or the desire to see someone about it and get it treated really is determined by the degree of bother for that individual patient, right? As I said before, some people can be leaking all the time and they have no problem with it, or they think it's normal, and so they don't get anything done. Whereas other people are, have a small amount of leakage very occasionally, and it's the end of the world.
That's
And
me.
that's when yeah, well, exactly. So I mean, it really depends on the degree of bother for that specific patient, right? And the number of patients that I see with this type of issue, I mean, it's the whole spectrum in terms of degree of bother. So,
Yeah.
I mean, in terms of when to seek help, certainly if you're having issues that are lasting postpartum, I think seeing your family doctor. Or looking to see if a pelvic floor physiotherapist would be good options to start. But I think as physicians and as healthcare professionals, you also have to make it sort of a safe space to be able to seek that help, right?
Mm-hmm.
Sometimes patients don't have that opportunity. They don't have a family doctor. Some family doctors don't really want to deal with this, or want to refer, and some specialists don't specifically deal with this issue either. So it can sometimes be a bit of a hard time navigating the system to get help with this. So,
Yeah. Like most female issues. But anyways,
well, I mean, male issues too, but come on.
yeah, I suppose. I'll just say for me, incontinence, I did not experience it until 18 months postpartum. And I remember, I will never forget when it first happened. You were at work. It was during quarantine, like during the pandemic. And I was making a TikTok dance with Milo in the kitchen. And as I was like jumping around, I think I had to go pee. Like whenever I've experienced it, it's been like my bladder is full and I'm holding it. And then something happens and then I leak. It was like either I would sneeze or like jump, like to do a dance or something. And so, but for me, it didn't last. I obviously was doing pelvic floor stuff before and after pregnancy, which I think helped. But yeah, for me, it was like my degree of discomfort for like very minimal leaking was very high. And so I, sought out help like right away. Okay, so what does it mean when you go pee, but then almost immediately feel like you have to go pee again? Like this is the story of my life.
So I mean, the term we use for that is something called double voiding. So you pee, you still have the sensation you need to go, and then you pee again. Oftentimes that can be associated with something called overactive bladder. So where your bladder is sort of it wants to contract even with smaller amounts of urine, and when it does contract, it may not be efficient in terms of completely emptying itself. It also can be related to incomplete bladder emptying, so you're not completely emptying your bladder when you go pee the first time, and that small amount there is still, is still giving you that sensation or urge to go. When we're trying to delineate sort of what the difference is, it's always good to ask about other symptoms like urinary urgency, nocturia, or waking up at night to urinate, the number of times patients are voiding during the day, and oftentimes it's good to obtain some imaging. You can either do that with like a formal pelvic ultrasound or something called a bladder scan, where you basically assess after a patient's peed how much of urine volume is still left in there to determine if there's any retention.
The next question is, can constipation or bloating from IBS contribute to incontinence? I always wonder this too because I struggle with constipation.
Yeah.
Like
You?
me.
I know. I'm being sarcastic. Yeah.
Like, hello.
Well, directly attributing it is a bit challenging, but certainly, from an anatomical perspective, your rectum sits directly behind your bladder in the pelvis. If you have a full rectum a rectum that's full of stool, I mean, certainly that's going to put pressure on the bladder as well, just like a uterus would, and certainly could lead to some overactivity, mainly like urgency incontinence. So that would be the main sort of mechanism for that. At the same time, if your pelvic floor muscles are really contracted and trying to hold in all that stool, that can also have detrimental effects on your bladder control.
Like, the feeling when you have to go pee? Like, it's weird because I'm not a man, so I don't understand like what you feel versus what I feel when I have to go pee. But is that what urgency means? Like, it's like you feel like, because
you
I
gotta go, you
swear,
gotta go, right?
like
that's
90% of the day, I have that feeling like I could go. Like, I could go sit on the toilet and like probably get pee out like at any time. So that's what urgency means?
Yeah.
Oh, okay. Okay. Somebody asked about pelvic floor physio. I'll just go over this quickly. So it says, when should someone start? I think it's super helpful to go at any time just to learn. And I will explain what that visit is like in case you're wondering, because I don't think a lot of people know. You will meet the pelvic floor physio. Maybe some do consultations first before they do the actual internal exam. It's an internal exam. So what I was fascinated by is that they will
Get
help
in
you
there.
do, yes, they will get in there. They will help you do a Kegel properly. So they're going to have their hand literally inside of you, or like fingers pressing on the specific muscles on the inside of your, like, what's the proper anatomy term? Like vaginal wall or
In the vagina,
in the vagina. Okay.
yeah.
And so I just don't want to say the wrong word. And so they will press on, like, they will ask you to flex and like do Kegels while their finger is inside pressing on these certain muscles. And they will be able to tell you whether the muscles are weak, well, whether they are like too tense. And in my situation, it was that I am constantly like in a tense, like I'm,
Or
what's the
hypertonic.
hypertonic? Yeah. And so I think oftentimes, and this is the next question that I'll let you answer, but I think a lot of people assume that they have weak muscles when they leak, and that's not always the case. For me, it was like I am over tensing them all the time. And then as soon as there's any pressure, they're so weak that they can't like do anything. It's like, I remember talking to a girl a while back, and she gave the example of like if you're carrying grocery bags that are super, super heavy and your bicep is like constantly tensed. And
Yeah.
then if you go to try and use your bicep, it's like it fails because it's so overworked. So I am like a huge, like, I would say you should start as soon as possible. Just go see one,
Yeah.
learn about your body, learn whether you're hypertonic, whether you're weak. They'll teach you how to do a Kegel properly. So yeah, I would say just get on
Yeah.
it right away.
I mean, I think it's like, I think you have to look at pregnancy as like it's a huge stress, right? It's a stress on your body, and so making sure that you're, as ready for it as possible, whether it's with exercise, pelvic floor physio, I think that's going to be helpful in being proactive
Yeah.
in terms of controlling it, right?
Yeah. Work out your core, work out your lower
Yeah.
back, work out your upper back. Like these are things that people don't talk about. And like my sister just had her baby in June, and she can't believe how sore her back is. I was like, why are people not talking about how much you should like strengthen certain muscles before having a kid?
Yeah. And the other thing is, we talked about the fact that it's kind of mixed incontinence that can happen during pregnancy. You know, typically for patients who have the urgency component of it, if they're not pregnant, we're looking at potentially starting medications and things trying to relax the bladder. It was never a great idea to do that during pregnancy, and so you have to look at pelvic floor exercises as sort of the mainstay of treatment during pregnancy. And so if you do that ahead of it, you're going to be setting yourself up for success there.
Okay, so let's talk a little bit about pelvic floor weakness versus hypertonic and how both can lead to incontinence. I kind of went over it with like layman's terms, but go
Yeah.
ahead.
I mean, weakness, as you said before, the pelvic floor muscles are a component of your sphincter complex, your control mechanism for urination. If you have weak pelvic floor muscles, you're not going to have that same contraction and sort of pull up on the urethra when you're doing any type of strenuous activity. So weak pelvic floor muscles certainly lead to urgency or stress incontinence rather. Hypertonic pelvic floor muscles, so when your pelvic floor muscles are tight all the time, that can also secondarily lead to weakness because they're always tight, and then you lose that contraction over time. At the same time, it also can have impacts on your ability to empty your bladder. So if it's really tight, it's going to kind of constrict your urethra a bit, and that long-term issues in terms of having difficulties emptying can lead to overactivity of your bladder. So your bladder wants to contract more frequently with more force to try and empty against this pressure that's being exerted by your pelvic floor muscles. So it can lead to both, right? So stress incontinence due to weak pelvic floor muscles, and urgency incontinence typically with hypertonic or overactive pelvic floor.
Okay. I'm gonna skip the next question because we already kind of talked about like seeing like the
Yeah,
steps that you would take to get help. So family doctor,
yeah.
pelvic floor physio.
I think it also depends on where you live, right? So, I mean, in Canada,
Yeah.
our system is based on, being referred to, specialists from your family doctor typically. So you kind of have to see a primary care physician like that first, and then get referred to a specialist. It's just the way that funding and payment models work. If you're in the U.S. or places where they have public or private healthcare, oftentimes you can just self-refer for issues.
Yeah.
Whether we won't get into the pros and cons of that, but that's a
You
whole
know me.
different
I
discussion.
would be self-referring like,
You, you'd be
every
seeing
week.
you'd be seeing every person, and you'd be broke. So yeah,
Uh, okay. Is there a way to tell whether someone would need surgery versus just physiotherapy?
yeah. So I mean, some patients who have significant leakage can benefit from pelvic floor physio and sort of get to the point where they're comfortable or even completely dry. Some patients who have relatively minor leakage can't get improvement when they are using conservative measures like that. So, I mean, I think the important things, just from sort of basics, when I see patients who are taking a history, physical, kind of determining the type of incontinence they have, the degree of incontinence they have, and then if there's any sort of red flags to any other abnormalities, things like fistulas and things like that, which can happen during or as a result of labor. They're pretty uncommon, especially in North America, but they do happen. So you want to look into sort of red flags for that. So patients who have continuous incontinence, for example, like there's no rhyme or reason as to why they're leaking. They're kind of leaking small or large amounts all the time without even any activity. Um, those patients would need sort of other investigations, things like urodynamic testing, which is looking at the pressures developed in your bladder as it's contracting, or as it's filling and contracting, I should say, and also cystoscopy, where we kind of look inside the bladder. It's a little scope procedure to assess the health of the bladder. We often try conservative measures first as a starting point. So things like timed voiding, reducing your fluid intake, pelvic floor exercises, whether that's with Kegel exercises that anyone can do, or getting a formal pelvic floor physiotherapy assessment and treatment. Um, if those fail, then or patients can't do it for whatever reason, the degree of incontinence is so severe that it's not going to be beneficial, or it hasn't been beneficial, then typically that's when we make the decision to move towards surgery.
What does the surgery do? Or is it depending on the
Yeah.
issue?
So, I mean, surgery in these situations is specifically for stress incontinence, or patients who have stress incontinence predominance. If there's mixed incontinence, and essentially there's different types of surgery. The general idea behind these procedures is to place something in the pelvic floor where those muscles are, but have lost strength, to give you
Hmm.
support that's been lost, right? So
Okay.
there's various methods of doing it. The methods that we're currently using most often are mesh procedures, where you place a proline mesh underneath the urethra. It's a vaginal incision that's typically made there. It's a relatively quick operation. It's only about 15-20 minutes in the operating room.
Hmm.
It is, I mean, it's a relatively big procedure in terms of recovery and things like that afterwards. You don't want to do too much too soon, but the actual procedure itself is not that involved. And it's an outpatient thing. Some people do it under complete anesthesia or general anesthesia. Some people do it under sedation. Some even under local anesthetic. It just depends on where you go. But essentially, like I said, we're putting a mesh underneath the urethra that creates kind of an inflammatory response and gives you this support that's been lost. There have been some issues in terms of mesh complications and things that have been widely reported in the media. Not as much for this type of use of the mesh, more for patients who've had um, prolapse issues where they're using large amounts of mesh in the pelvis. But somebody has had issues with that before, or just doesn't want this foreign body inside. Then there's another procedure called a pubovaginal sling, where we kind of use the lining of your abdominal muscles to create this sling instead of a mesh.
Hmm.
So
Oh my, medicine. Okay. So a little bit of a discussion about Kegels, and that commitment is key, just like any other exercise. So
yeah,
yeah, and the fact that just like any other muscle that you're working out, if
yeah.
really work it out for 6 months and then you stop for 2 years, like you're gonna lose what you built
or
up.
or you don't do it enough, right? I mean, you would be surprised how many people come in here to my office who, they were told about Kegels, they've tried them for like a month and not even consistently, and the whole thing is the Kegels haven't been effective.
Mm-hmm.
So it's making sure you're doing them and also doing them correctly. So
Yeah.
that's where things like instruction come into play, whether that's seeing a pelvic floor physio, or even looking at things on YouTube or online as to being able to isolate those muscles properly. That's the you want to make sure that you're doing it correctly, not just doing it for the sake of doing it.
Okay, I just want to say that when I went and did my Kegels with a pelvic floor physio, um, she said that I had almost like Olympic strength, like
I,
Kegel. She could not believe how strong my
I've
pelvic
never
floor
heard of
was,
Olympic Kegeling
babe.
before. So is that like some new sport in the
I
Olympics?
don't know, but I should find out because
Yeah.
I could get a gold medal. Anyways, okay. So one question. Oh, this is a great question. And this happens to me all the time. And it's embarrassing because I'll be like, oh my God, I have to pee so bad. I have to pee so bad. And then I finally get into a washroom. And if it's like a public washroom and I'm with like my mom or my sister or something, and they're like, I thought you had to pee so bad, but it won't come out. So why is it hard to pee after you've been holding it in for so long?
Well, I mean, that can be due to a number of things, right? So you're holding it in if you feel like you need to go, but you can't. Then you're tensing your pelvic floor muscles. And, as I said before, that tension around the urethra can cause a bit of an obstruction, and that can have impacts there. At the same time, if your bladder is really overfilled and stretched, it's not really in the right position to contract, and it has less force to contract.
Yeah. Oh, I hate that. And it takes a while. Like I'll sit there and it's like silent, and I'm like, okay, like you thought you were gonna pee your pants, and now it's not coming out.
Well, at least you didn't pee your
Um,
pants.
yeah, I guess. Okay, so in the meantime, I just want to reiterate people who don't want to see a physio, maybe you don't want to be referred to a surgeon, but you're experiencing incontinence, or maybe it's going to take you some time to get in to see somebody. TENA does have products that will help you stay comfortable during the day. Also at night, they keep you dry, they keep you odor free, they are comfortable. TENA is the leader or the global leader and trusted expert for offering superior sustainable solutions that help manage urinary incontinence, leakage, and bladder weakness both day and night. I was looking at their products. They have liners, they have pads, they have underwear, they have briefs. I'm going to do some ordering because anyways, I won't get into it. But so if you want more information about what products they have, and they have a ton of information on their website just about incontinence in general, you can go to www.tena.ca and check out, their entire range of products. And this was a great way to spend your lunch hour. So thanks for coming on and talking about incontinence.
Anytime.
And are you picking up Milo from school today?
Hopefully, we'll see.
All right. I guess you have to get to your patients, and then you'll be able to pick him up.
Yeah, exactly.